Hello everyone, my name is Nehemi George and my DMP project that I'll be speaking about today deals with the DASH diet, or dietary advances to stop hypertension and to help lower patients' blood pressures. So my chair currently is Dr. Snell. The second reader is our course instructor, Dr. Davis, and my community member is Dr. Maya Vishnu. She is also the clinic owner of the site that I used for the project. I just want to outline her for being very supportive in this process, and I owe a lot of help for her help for helping me during this project. So, the purpose of this scholarly project was not limited to lowering the occurrences of issues related to hypertension, but to also make patients more aware of the options available regarding modifiable factors and their options for action. Giving them education on modifiable factors to help lower their blood pressures can prove to be more of a long-term solution than maybe a pharmacological intervention would be. Although systems kind of already exist to provide education regarding diet, there wasn't necessarily a consistent education system that I saw that was being given to patients nationally or universally. So, some background information I talked about. I discussed detailing what exactly blood pressure was, in that it's the pressure that's within our arteries, where a certain pressure is needed to perfuse our organs, but there's a range where too much pressure can cause damage. This can occur, for example, within the kidneys, and damaged kidneys can kind of further exacerbate blood pressure issues, and it's kind of this unfortunate cycle where bad blood pressure can lead to even worse blood pressure. So that's why it's important to address it early on. There's also, genetics also play a big role, but lifestyle modifications was the main focus of the project. While more than one reading is required to establish a diagnosis of hypertension, this intervention was implemented at the first presentation of an elevated blood pressure. The literature for the DASH diet is plentiful and largely in support of the relationship between hypertension and dietary intake being correlated. Certain studies talk about sodium restriction and reduction, in that the DASH diet has to reduce, the mechanism in which it reduces blood pressure, and variations surrounding the versions of the DASH diet as well. One variation that I wanted to include and specifically talk about is the Mediterranean diet. Well, I saw a lot of studies focusing mainly on the DASH diet's relationship with the low-sodium Mediterranean diet and their relationship with one another. The Mediterranean diet itself was thought to have a less significant effect on blood pressure than the DASH diet, but they were thought to be related in that sodium content of a typical Mediterranean diet would be like a low-sodium Mediterranean diet was being recommended a lot of the time. There was a lot of comparisons made between the two whenever I was doing this literature review. Another aspect of consideration, it dealt with adherence to the DASH diet and being culturally competent with consideration to the patient's cultural diet preference. We'll kind of readdress that a little bit later as well in this presentation. But there was also a discussion of using the DASH diet in conjunction with pharmacological intervention, as the DASH diet's mechanism of blood pressure reduction was more so independent of the pharmacological interventions used. from medication. So, for the theoretical framework that I discussed, it dealt with Pender, Murdaugh, and Parsons' health promotion model. The goal is to help patients stay healthy even though they're facing illness, and to promote healthy environments with factors in consideration such as the socioeconomic condition, the physical environment, and health behaviors. The patient's experiences and interpersonal relationships, all these three factors play such a significant role in the way that they implement educative practices for their health. My project mostly fits into the health behaviors category, where we're trying to change and modify the patient's diet. Dietary interventions, while they are non-pharmacological, a non-pharmacological intervention, it's important to consider that sometimes it can be an expensive alternative for patients, even though, in comparison to pharmacological intervention, many factors are involved in the way that patients prepare food, from the ability to cook to the time that they have to cook. The combination of these factors and the inability to access healthier foods, gyms, and education, even coming to the doctor itself, and catching this primary intervention of catching blood pressures. It's all related to a healthier lifestyle that can contribute to controlling this elevated blood pressure. As for the method and design, a quantitative method through a retrospective chart review was completed so that while patients weren't directly engaged by the researcher or myself, the participants were educated by the practitioner of that clinic. Retrospectively, the blood pressure data was collected pre- and post-interventionally in the clinic. To put it simply, patients who presented with an initial blood pressure reading, as noted in the electronic medical record, during the review were included into the data. After their follow-up, the post-interventional blood pressure was also recorded. Just to kind of go through some of the inclusion criteria that I had implemented, the participant needed to be between the ages of 18 and 89. They needed to have an elevated blood pressure reading or hypertension during their initial visit, which I denoted as above 130 systolic blood pressure. They also needed to have documentation that they had a follow-up in the office after implementation with a recorded blood pressure. So we had a post-interventional blood pressure. And yeah, the data collection sheet I used was made by myself and was just made to more easily kind of collect blood pressure data while keeping patient data anonymous. The education itself, I want to talk a little bit about. It was a pamphlet of data that was already present within the EMR of the clinic, so outside information wasn't necessarily taken into the clinic. It was a resource that they already had available that wasn't being implemented. So the information is easily accessible. The practitioner aligned her teaching with that pamphlet and gave it to the patients for their reference at home. Okay. So the sample size. It consisted of 42 patients total. 30 of those, or 71.4%, of these patients had an initial systolic blood pressure range of 130 to 139. 11 patients had a blood pressure range within 140, 149, or 26.2% of the patients. and the last remaining one had asystolic blood pressure above 150, or 2.4% of the participants. I included a small histogram here on the right side that is also included in my paper to more easily help portray that data visually. As you can see, a majority of the patients had a slightly elevated blood pressure, as it's kind of more shifted toward the left side of that histogram. So data analysis. In the analysis portion, the first completed test that was done with the assistance of Dr. Pauls was the Shapiro-Wilk test. So the reason we completed the Shapiro-Wilk test was to check for normality. And that was to make sure that we can use the paired t-test. One of the requirements for the paired t-test is that the distribution for the change of data needs to be normal. So after completing the Shapiro-Wilk and confirming normality, the paired t-test was chosen to compare the paired set of data for the patient's blood pressures. So other calculations that we'll talk about on the next slide are the effect size, which talks about the change in the difference between the pre and post interventional blood pressures in terms of standard deviation, whereas the power is the probability of the outcome of the intervention will be significant. So the takeaway from that basically is that a strong power would mean the intervention is reproducible. So onto the results, kind of briefly talking about it. The paired t-test showed a significance on one side. It was a two-tailed test. It means, in short, that the data had significance on one side, or a reduction in the blood pressure. The effect size showed the amount of change based on the standard deviation, and the power is 0.844. It's basically saying that it had a strong power and was, in this test, is reproducible to get those results. So limitations is something that I want to kind of talk about deeply. There were some factors that I think could have been more consistent between each patient. For example, the literature for the DASH diets took into account the adherence patients had with the intervention. But in this case, the patients that they were just presented with the DASH diet information to complete at their own discretion. The amount of adherence could have varied greatly between each patient. There also could have been variance between patient blood pressures, in that some patients could have been taking pharmacological intervention or had a change in pharmacological intervention that wasn't taken into account. Another aspect that I want to talk about is timing. The time between the pre and post interventional blood pressures was not consistent between each patient. The practitioner was given an ideal range of 2 to 3 months for a follow-up, but she couldn't follow that exactly each time for each patient. Sometimes they were longer and sometimes they were shorter. Dietary interventions like these would likely take some time to have an effect. So lastly, I wanted to talk about the lack of a control group to make a comparison with. So ideally, patients with elevated blood pressure, some of them would not have had the intervention, but in this case there wasn't a control group to make a comparison with. With consideration of the data and the analysis presented, the results point to the DASH diet effectively lowering blood pressures of these patients that presented with elevated blood pressures positively. But it's important to keep in mind these limitations that we were just talking about with the data, the analysis results. So, implications for practice. In practice, the education should be used as a first-line intervention related to its ease of implementation and low risk. It can help create a long-term and like a lifestyle change for these patients that will help them opposed to a pharmacological intervention. Pharmacological interventions do have their place and they are important, but if the issue can be resolved without the associated risks, it could be more beneficial for the patient in the long run if they can make these lifestyle changes that would prevent the issues from occurring in the first place. Policies surrounding education of healthcare professionals and continuing education itself could be put into place to help teach patients, and these practitioners to help teach patients regarding recommendations. Public policies, such as in schools or even in the workplace, could help supply the education, the foods that help follow the DASH diet to help promote lower blood pressures. So, in conclusion, the patients were given education regarding the DASH diet when presenting with an elevated blood pressure. After analysis, it showed that patient blood pressures decreased in a significant way, leading to the conclusion that educating patients with this intervention can help positively affect lowering blood pressure. Unfortunately, as we were discussing, there were a lot of variables to consider in the study that could have been implication for further testing. I think further studies or repeating this intervention with more control on those variables could possibly lead to another result. But I think future research can also take in consideration for other variables of the DASH diet, including cultural implications, such as we were just talking about earlier, the cultural diets similar to the DASH diet being that Mediterranean diet. Although maybe the Mediterranean diet didn't have as much of an effect, helping following patient dietary preferences could be more important in helping patient adherence to follow these interventions and could lead to more success in lowering blood pressure than maybe the typical DASH diet could, or maybe in the fact that some of the literature review I saw kind of focused on variations of the DASH diet for certain ethnicities, for example, African Americans. Some variations were more effective for them rather than other ethnicities were. Here are the references I talked about in the presentation, and I want to thank you all for listening. And yeah. Before completing, I do want to talk about the DNP program itself and what I've learned. Apart from clinical knowledge I've been able to gain from this program, I think that gaining the experiences I've had during my clinicals and during the implementation of this project itself has kind of opened my eyes to a perspective on what kind of a role a practitioner has on patients. While we can't force patients to live an ideal lifestyle and healthy lifestyle, we can arm them with the knowledge to help make positive choices for their health. And accessible healthcare opens up this avenue of education and helps that become more possible, especially in the state that our current country's healthcare is in. I think that's really important. I really want to thank everyone that had made this program possible for me, and all the teachers and professors that helped me in making this project possible. Thank you again, and thank you for listening.